Good morning. We are going to start this breakout session on TAVR. I am Marta Sitges. I am a cardiologist working in Barcelona, and I have the pleasure to co-chair this session with our first speaker also, who is Jessica Forcillo, a cardiac surgeon working in Montreal. And we are also co-chairing with Vinod, that will be Vinod Turani, who will be joining us in a few minutes. So Jessica, you're the first speaker. On which valve do we need to use for which patient?
Thank you. So it's a pleasure to be here. Can we have the slides, please? Okay, so I'm a cardiac surgeon performing TAVR. I was trained actually during my fellowship by Vino. I'm the surgical director of the structural heart program. So these are my conflict of interest. So basically, the heart team, before we were discussing about patient risk category and which patient should have surgery, which one should have TAVR. But nowadays, because we have access to so many other platforms, the discussion are longer because we really want to choose the proper valve for the right patient. And in terms of the consideration for that, we're going to start with the anatomical consideration. So if we look at patients with large annuli, we know that contemporary THVs are commonly available in 3 to 4 different sizes, covering annulus diameters between 18 and 30 millimeter. In the case of larger dimension, the options are either to use the larger valve, and there's also the MI valve that has an extra large that can cover also annular dimension from 30.5 to 32. But there has been assessment as an ex vivo setting that conclude that overexpansion of the valve, so you can add more cc's in your valve can be feasible, but suggested that excessive overexpansion may increase the risk of acute leaflet failure, impair function, and reduce durability. There's case series that were done in annular dimension that were 800 to 1,000 recently, that was published in 2024. They put like 7 milliliter more in the balloon. In patients with annular dimension that are borderline between 2 prosthesis size, usually, and we look at the calcification distribution in this patient, but we consider the smaller valve just to have the proper expansion of the valve and to avoid the pinwheeling of the leaflet. For the small annulus, it bears the risk of high procedural gradient and patient prosthesis mismatch, which is more frequent with intraannular device. However, the SMART trial also compared between self-expandable and balloon expandable valve, and in terms of the clinical outcome, it was the same, but the self-expandable valve were performing better in patients with smaller annular, and there was less bioprosthetic valve dysfunction during 1 year period in the supraannular valve as well. Coronary obstruction is a rare, but it can be a fatal complication with a high fatal complication. But the thing is, we can prevent that with the pre-procedural scan that we're doing. And there's also non-anatomical risk factors that you should be aware of in terms of the coronary obstructions of female, higher implantation, etc. And basically, there's a low risk of coronary obstruction that can be anticipated just for self-expandable valve, but at the same time, it's just because you can reposition or retrieve it prior to final deployment. In contrast to surgical aortic valve, the amount and distribution pattern of aortic valve calcification have a higher impact on outcome for TAVR patient. This has been demonstrated for self-expandable and balloon expandable valve that indicate a higher risk of procedural complication when you have extensive calcification such as annular rupture, and you may need the need for post-dilatation in these patients, and also higher chance of having perivalvular leak. When you have calcium and asymmetric annulus protruding into the left ventricular outflow tract, the selection of a valve with an advanced external sealing skirt may be preferable as well. However, to date, there's no randomized comparison of different THV according to the degree and distribution or of aortic valve calcification. For the horizontal aorta, the implantation in the horizontal configuration of the ascending aorta is regarded as challenging due to difficult positioning, especially in self-expandable device with long stent frames. But the data on the impact of horizontal aorta on procedural outcomes are scarce. But we tend to use THV device with short stent frames that are more appropriate choice for this anatomy, and also the balloon expandable valve with the delivery system with dual articulation and distal flexing allows for facilitated crossing of the arch and positioning. Bicuspid valve are different morphology and different types compared to the tricuspid valve. They are frequently associated with larger annular dimension, extensive and complex calcification pattern, asymmetric valve orifice, and a dilated aortic root and ascending aorta. However, available registry-based analysis show that TAVR in bicuspid is safe, and particularly with the newer generation valve. But however, future research in terms of differential device selection and long-term durability is required, especially in those younger patients. We know that left bundle branch block and conduction disturbance, such as with requirement of pacemaker, can be a complication of TAVR implantation. And there's predictors of requiring pacemaker after, such as right bundle branch block. There's several other risk factors that you should be aware that can increase the chance as well. But however, in the literature with the new device, the rate of pacemaker is decreasing, and especially because we learn with the experience how to implant. We implant higher, we implant in different view, the two-cause view, for example, for the core valve, and we can measure also the length of the membranous septum on the CT scan to prevent those complications. Alternative access nowadays, mainly transcarotid, transaxillary. So the choice of the delivery system is important. The diameter of the sheet is important because you don't want to occlude the vessel. And there's a correlation between vascular complication and the size of the sheet. So I tend to use the Evolute FX for my alternative access. You can use the Commander system of Edwards as well. And now we're going to start, we talk about the anatomical consideration, we're going to talk about the patient's comorbidities. So patients with reduced LVEF and severe aortic stenosis have poorer prognosis after aortic valve replacement due to the associated pathological irreversible myocardial fibrosis. And in the absence of reliable evidence, it can only be anticipated that rapid pacing, conduction abnormality, relevant PVL, and high post-procedural gradient are particularly detrimental in cases of severely reduced left ventricular function. Coronary artery disease, there's scarce results in the literature. So I think that we're going to have more insight about that with the complete TAVR. So should we revascularize first or should we do the TAVR first? Our institution is doing a complete revasc strategy first because there's incomplete revasc was demonstrated to be an independent predictor of decreased left ventricular recovery and was associated with certain study with higher one-year mortality. Also, we should anticipate to return in the coronaries just to be able to dilate in the future as in the disease progress. So usually the sapien, the navigator, the valve with low stent, open cells, intraannular, typically permit unrestricted future reaccess to the coronary. FX Plus is on the way with the larger cells, and if you plan to do a TAV-in-TAV device to cut the leaflet on the valves are under development as well. We talk about patient-prosthesis mismatch and the hemodynamics that is super important that could correlate with the durability also of the valve and to the freedom from SVD. In terms of the clinical data and durability, as comparative data on long-term performance in the currently available THV systems are lacking, valve durability cannot yet be used as a criteria for differential selection. But we saw that with the Notion trial that the longevity, the durability should be, we should anticipate to be maybe 10 years, and there's low rate of structural valve deterioration. So life expectancy, lifetime management is important. So we should think about the future of TAV-in-TAV. There's a device that offers the commercial alignment, and basically understanding the characteristic of these valves is crucial for comprehending the challenge posed by TAV-TAV in procedure in the future. So, like I said, with the TAV-in-TAV, it's completely different. The old cells are pin open during valve-in-valve implantation, forming a cylindrical narrow skirt in the aortic root that can cause sinus sequestration. So we should look at the VTSTJ to make sure. If not, there's other maneuver that you can do, the chimney, the basilica, etc., to prevent this. because the fact is that a third of the patient will not be eligible for repeat TAVR, and up to 25% of patients from the explant TAVR registry were low-risk patient candidate, although a breakdown of how many of these were bicuspid was not provided. So I think that it's very important now to have 3D modeling. So this is our team at the SHIM with the physician that we work with. We replicate a model of the root. This DASI simulation model is used in the States and can be very useful as well. So I think that these adjunct can really help us to prevent those complications and to be able to choose the proper valve for the patient. We present that abstract last year at the Heart Valve Society. My student won the award for the 3D modeling. We published some case report. We use that frequently, this model. We simulated in the under fluoroscopy, and after we validate with what we did. So basically, in conclusion, none of the currently available THVs are capable of addressing the full spectrum of challenging patient anatomies and clinical situation in a comprehensive fashion. However, some device may be more appropriate for use in specific patient and results in better outcomes than others. The question on which or how many different device centers should keep in stock mainly depends on the TAVR volume. Centers with low volume usually have only 1 or 2 valve types in stock, and that could be sufficient. In center with higher volume, it is recommended to have the different device that can offer a larger spectrum. So due to the specific advantage and disadvantage of each THV system, it is strongly advisable to make use of the broad spectrum of available treatment options in TAVR technology and to select the most appropriate device according to the anatomy and the comorbidities of the patient, and leveraging national registry to conduct observational studies assessing the real-life safety and comparative effectiveness of different TAVR devices should also be considered. Thank you.
Thank you, Jessica. Questions from the audience? If not, I will start. Yeah. So it seems that for TAVR, transcatheter aortic valve replacement, we need more precise assessment of the anatomy because we don't have so much control, and therefore anatomy really has a big implication on the selection of the prosthesis. While for surgery, probably you don't rely as much on the anatomy. And you can change, indeed, no? On the moment. But how much does anatomy impacts on your decision to do surgical AVR or transcatheter AVR? I mean, you can do both, but so is only a problem of comorbidity or also anatomy?
I think it's both. And also, I mainly think about lifetime management as well. So should this patient will have 1 procedure or should this patient will have 2 procedures? What is acceptable for this patient in terms of that? Because repeat surgery, TAVR explant as surgical mortality, morbidities. Now we learn we're better at explanting those valves and the mortality is less because we learn. This is the experience. But definitely for a patient, that's the type of discussion that we have during the heart team, and it's really challenging. And sometimes, like us surgeon, we recommend TAVR, and the cardiologist will say, no, you should have a mechanical AVR, because mechanical AVR is still a good solution for our patient, and it goes to just 1 procedure. But basically, especially that if we tell the patient that we're going to do a bioprosthetic valve or a TAVR valve, we should be able to know better that this patient will be able to have a valve-in-valve or to be able to have a TAV in the future if the lifetime expectancy of this patient is about 15 years old. Because if we don't know for sure, I think it's hard to tell that to the patient and make him believe that that could be the point. So the 3D, the DASI, the simulation model is very important for this patient.
So Jessica, can you just tell us how it's done in Canada? So in the United States, at our program, no surgeon is taking a patient to surgery in our heart center without a cardiologist, a valve cardiologist, having seen that patient. In the United States, you can't do a TAVR without a surgeon seeing the patient. That rule is not there for surgery, right? A surgeon can see the patient, operate on them, never. He could be 95 years old in a wheelchair. The surgeon can still go operate on them. But you can't do a TAVR on anybody without a surgeon seeing the patient. So it's a little bit disproportionate. How is it done in Canada? Yeah. Can you explain that to us? And then are you routinely getting CTs on every single patient who comes in with aortic stenosis? 2 questions.
I think that practice changed over the last year, and with what we've learned, and like people being more informed and educated about it. But basically, we try for patients that are 70 years old and over to do CT scan on all of these patients, and after these patients should go through the RT to have the discussion, because it's only fair to the patient to expose to him when you discuss with the patient.
70 or greater. Okay.
Yeah. Yeah, to expose what are the options for this patient, because he needs to know both, and he needs to know the benefit and the risk of having one or the other.
How about the patient from 60 to 70?
They probably will go to surgery. Yeah,
In Canada?
In Canada.
in Canada,
Yeah,
for sure.
And
And
Europe.
every center in
In
Canada
In Europe
who
also, so
perform-
not in the US.
Yeah,
Yeah.
but every center who perform TAVR in Canada, they have cardiac surgery on sites. So.
What about female?
Female
Two
patient,
recent controversial studies.
It's not, we look at the small annulus, we're very aggressive. So in my surgical practice, I do like annular enlargement in maybe 80% of my patient. So it's not something, because we are performing root enlargement during surgery. So it's not something that would favor one or the other.
That's great. I just want to mention Jessica, talking about mentorship earlier in the session before this. Jessica spent 2 years with me in Atlanta, and it really was one of the 2 best years and most productive years. I actually learned more from her than I taught her. And now we, even despite that, for 5, 6 years, we've continued to have this mentorship relationship. And so we encourage you to try to find that pathway for you, because it really propels you into the next generation like you've become, Jessica. Congratulations.
Thank you, Vina.
Thank you.
Okay, great. So now, having heard a really nice talk from TAVR, we're going to go on the other side. Senichi from Ann Arbor, University of Michigan, is going to talk about how he takes these out. Senichi is a master surgeon who also, like myself, and Jessica, does TAVR procedures, and he also does surgery procedures. So he really lives on both sides of the fence. Senichi.
Thank you so much for the introduction, and then we're going to talk about the explanting TAVR valve disclosures here. So this is take-home messages, particularly for, I think, cardiology doctors, not for surgeons, but the clinical relevance of TAVR explant is steeply rising. TAVR explant instead of redo TAVR is not the loss of a battle. So TAVR explant is rather really valid reintervention option post-TAVR. TAVR first approach for lower risk younger patients may be considered in carefully selected patients, given the improvement of TAVR explant outcomes. So I just quickly asked ChatGPT, what's the perception of TAVR explant nowadays? I think ChatGPT got the good points. Rising clinical relevance, underrepresented in cardiology literature, feared but essential in lifetime management, often deferred until critical illness, which is probably main reason why explant outcomes were not great in the past. Not discussed in TAVR RCTs. Yes, that's very correct. So what happened in the past 3 years in terms of TAVR explant related research? Probably many of you have seen this paper. TAVR explant pandemic, the more than 3,000 cases, TAVR explants were done in the US and then, North America. Mortality was 15%, which is probably higher than type A dissection repair mortality. For some reason, aortic procedures are performed in almost 30% of patients. But the STS database has the limitations, including no index TAVR information, no follow-up data. We also talked about this yesterday and this morning. In the U.S., at least 65 to 80-year-old patients are shared decision, SAVR versus TAVR. Younger than 65, SAVR. However, we are entering more than 50% of patients TAVR era for patients younger than 65-year-old in some geographic area. We cannot stop this trend. This is oftentimes driven by patients, and we need to shift our mindset. Let's talk about some redo TAVR data that This was published in Lancet, 1,320 redo TAVR using balloon expandable platform. But if we carefully look at the number of those procedures, so this TVT redo TAVR, 1,320 cases in the same period. STS TAVR explant, 2,700. So is TAVR explant the more common form of a post-TAVR reintervention than redo TAVR? Again, we are comparing apple and oranges, but this is just what's happening, possibly. This was presented a couple of months ago at the STS, Medicare data, 335 TAVR explant versus 800 redo TAVRs. So initially, the redo TAVRs are doing much better. However, beyond 1 year, in the longer term, actually TAVR explant survivors are doing so much better. So before 2021, TAVR explant was so feared, bad. That was our perception. And then now we are starting to understand TAVR explant is really increasing. And then now, wait a second, patients are probably doing better if they survive the TAVR explant procedure. So this is my suspicion. Redo TAVR is infeasible or only short-term solution, palliative solution, possibly in more than 50% of patients. So there are studies, image-based redo TAVR feasibility studies, and then those studies are saying that the 50 to 70% of TAVR recipients can have redo TAVRs. Is that true? So, I think people only talk about the prosthesis-patient mismatch, but it's a little bit more than that. So every time we implant the new valve, it gets smaller. I'm not blaming TAVR. I think that TAVR in SAVR is the same thing. This is just a most recent case that we did. This patient is 189 centimeter, BSA 2.2. He received a 20 millimeter SAPIEN inside the 23 trifecta. And then, this is happening everywhere now. We've performed the commando procedure in those post-TAVR or post-TMVR patients. 37 hardware came out from these 15 patients. So we always talk about the lifetime management, but how many hardware is enough? Every time we implant something, it gets progressively smaller. So, I think that every time we do something, it's not the perfect. So we have to think about that. So, and then it's not only the size, labeled sizing. Leaflets are thickened, lots of calciums. The original TAVR was already distorted. And then second TAVR may be underexpanded. Doesn't last as long as we think. So focusing on improvement of TAVR explant is, I think, the modern cardiac surgeon's task. So this special issue was just published in, online. Please just take a look. So this Annals of Cardiothoracic Surgery focused issue has all information about the TAVR explant. So this is all you need. So please read this. So let's talk about the rumor about the TAVR explant a little bit. So is it difficult to explant? So I'm gonna just, so I think the very important distinction between valve-in-valve TAVR explant versus native TAVR explant. So if that's a valve-in-valve TAVR explant, it's actually unbelievably easy. So this is all we do, just to take a cochlear clamp and then just twist, and it will come out. It's barely adherent to anything for most cases. And then this is a SAPIEN, same thing, just to take a cochlear clamp, then just a twist, and it will come out, usually less than 10 seconds. But when it comes to native TAVR explant, that twisting maneuver doesn't work, so we have to be a little bit more cautious. And then you can see if you twist, it gets really, you can possibly shred the aorta. This is what happens typically for native TAVR cases when you explant. So we typically take another cochlear clamp and then just get all the sharp edge facing towards the inward. And then just to spend a little bit extra time, and then, just nothing bad happens. You just have to be patient. Again, if this is native TAVR, if you twist, you can shred the aorta possibly. So you have to be a little bit cautious. So since this is a multidisciplinary conference, I just want to share some of the experience. This is one of the, when we do TAVR explant, when there are snorkel stents in the coronary, this is probably what makes TAVR explant very difficult. As you can see, those snorkel stents sticking outside the coronary ostia are really adherent. And every maneuver, when we try to explant the TAVR valve, those stents come out together. And even afterwards, when we size the valve, when we put those valve sutures, every time those snorkel stents are on the way. And so this is another case. Again, patient is only 64-year-old, but the patient got the bilateral snorkel stents and then tiny TAVR valve. So this is what we typically see. Those stents are already fractured inside because of the repetitive motion by the cardiac cycle, and then those stents are already fractured as we open. And as I mentioned, every time we try to do some type of maneuver, those stents come out at the same time as the TAVR valve. So we had to just snip the stents every time we do some maneuver. And then we didn't see even left coronary stent. We just saw that after the TAVR came out. But anyway, we have had 7 cases with this type of snorkel stents. Those are probably one of the most difficult cases when it comes to TAVR explants. So how about the concomitant aortic replacement? So this is a University of Michigan experience, but about 36% of patients during TAVR explant ended up having some type of aortic repair, but the operative mortality was numerically lower compared with the patients without aortic repair. So needing aortic repair is not associated with worse outcomes. And this is a breakdown. So many patients, because of previous root surgery, root abscess, or aneurysm, that's why they had the aortic repair. But actual injury by the TAVR valve is a very, very minority. So, and then, as I mentioned, it's not because of the procedure complexity. It is purely because of patients being very sick. TAVR explants are typically deferred until critical conditions. That's what we see all the time. Those patients are typically getting multiple workup studies, TAVR CTA again, cath, repeat cath, getting renal failure, finally after 6 months of a diagnosis, coming to see surgeon. That's what we see typically. And they are almost always near dialysis because of a kidney failure, class 3 or 4 heart failure. That's why outcomes are not greatest. Fortunately, University of Michigan experience, our outcomes for TAVR explant is progressively improving. And then, the fastest growing procedure in the US, so among the reduced SAVR cases, either after TAVR or SAVR, 2024, more than 30% of reduced SAVRs were post-TAVR setting at the University of Michigan. If this trend continues by 2029, the number of reduced SAVR after TAVR surpassed the number of reduced SAVR after SAVR by 2029. This is I was in Australia, just came back. This is there are 3 TAVR explants in 1 week. Next week, I had another 3 TAVR explants. So at least our hospital, it's increasing. Learning curve about the TAVR explant, 80 to 90% of TAVR explant procedures are actually not that difficult, but the 10 to 20% unexpected issues occur. And then some cases are horror stories, such as the snorkel stents, as I just briefly showed. But more importantly, learning curve includes timely operation. Just do not wait, just do it. That's a very important message that I'd like to give. I'm working on TAVR external device because of some IP reason. I cannot share the entire device, but this is a very nice addition to what we have in the OR. So hopefully this is something that we can share with everybody in the very near future. But easily you can use this for balloon expandable, self-expandable, any TAVR valve we can use. So in summary, TAVR explant, one of the most common procedures within 10 years. Outcomes are improving, fortunately. TAVR explant scenario is not the loss of a game. It's complementary to redo TAVR. So please do not delay timing of a surgical intervention. Thank you so much.
Excellent presentation, Shinichi. So my question is, what is the ethical dilemma about explanting those valves? What is the percentage of the patient that present who were deemed high surgical risk that you're going to actually explant the valve? And with this percentage of mortality for an explant TAVR, it is reasonable to tell the patient that, okay, you're gonna have your TAVR first, especially when you're younger, so you're gonna recover, be super active after, and we're gonna do your AVR later with this 6%, for example, which is excellent for your center because you have a huge experience, but it's not gonna be the case in all the centers. So is it acceptable?
Yeah, so the TAVR, we also in the special issue that I shared in the slides, we shared our latest experience, but those originally high-risk patients are actually interested in doing very well post-TAVR explant, but instead, originally low-risk patients are the ones who are actually not doing well, unfortunately, at least at our site. And then I believe, as I mentioned, it's because people are so reluctant to go through the explant process, and then that's actually what's hurting the outcomes. So I think as a society, I think we should share our experience with the cardiology doctors and then vice versa. I think the valve reintervention strategy is it's all complementary. TAVR explant, redo TAVR. I think we should offer what's best for each patient. So
I think you're right, Shinichi, that I've done over 50 explants now, and we are very aggressive about if they need it, we do it. And so rarely am I operating on patients who have renal failure and on dialysis at this point, quite honestly. And we have a 30-day, knock on wood, we have a 30-day mortality because we're not waiting till they're severe COPD, on dialysis, walking in with an EF of 55%, now down to 20%. So because we're seeing all the patients in our own valve center, and I see them on Mondays with a cardiologist, we quickly pop by, we see them, and then we operate on them. And so that's why we have a 0% mortality with these patients, because we're very aggressive about it. So I agree with you. The question is that how do we, I think part of the problem is that too many surgeons who don't 100% know what they're doing try to do these cases. How do we do these only in certain centers? Or, I have 6 surgeons in my hospital, only 2 of us do these. So how do we teach this to the rest of the community? Because a 10% mortality is the reason cardiology doesn't send these patients for surgery. How do we change that landscape?
Yeah, I think to be honest, also, I have some most updated Medicare data that I know more than 50% of TAVR centers had a 0 TAVR explant experience, And then, so I think showing TAVR explant is not something bad. We have to share our experience that TAVR explant is actually, particularly longer term patients are doing very well. So this way, I think cardiology doctors, they try to refer those patients quickly rather than waiting too long. And then I think those procedures eventually should be done at the probably selected the centers rather than being performed everywhere. But I think we had to just show the data first, and then, yeah.
So by the way, I also do it the way you do. I transect the aorta about a centimeter above the edge of the valve. And so and then you rotate the aorta to your face. And at that point, I use a 15 blade instead of doing all the turning. And for me, the 15 blade is caused. I've had one patient with damage to the anterior leaflet of the mitral valve when I was doing a lot of twisting. But so now I use a 15 all the way through. So different styles of doing it.
Thank you so much.
Thank you.
So it is my pleasure to introduce Dr. Vino Thurani. He's going to discuss about is TAVR for AR ready for prime time.
I see it. Great. Thanks. Yep. Just do 10, 12 minutes. Yep. Thanks. I'm sorry for those of you who were here yesterday. The topic that I was given is very similar from yesterday, so I will kind of go through these quickly. These are my disclosures. So the ACCHA guidelines, really when it comes to TAVR for aortic regurgitation, there's really nothing there. And this is a complete void for anything to do with transcatheter valve. You can see here for aortic regurgitation, nothing does it say about transcatheter valve therapies. And if you look at the European guidelines, again, there's nothing about transcatheter valve therapies in any guidelines for AR and TAVR. Now, having said this, the Jena valve, which is the only, it is the valve approved in Europe, and in the United States by the end of 2025, it will also be approved, as far as I understand it, also for the United States. Historically, and I've done a lot of these cases, we've used the Sapien and the core valve and the Navitor to treat patients that were not made for aortic regurgitation. And you can see that the device success rate is 84%. That means that 16% of patients had an early failure, which is very high in my opinion. And look at the 30-day mortality, 11%. Not very good in my opinion. And the moderate severe AR is 14%. That is, to me, it reminds me of 2006 when we were first starting doing TAVRs. And of course, there's also more recent, in 2023, the Pantheon registry, which had 201 patients, showed exactly the same data, 83% success rate, and a 12% valve embolization and migration. So very poor outcomes, in my opinion, for transcatheter valve therapy. I've talked again about this. I'm sorry for those who were there yesterday. There are two main valves that I'll talk about. One is the Trilogy valve. I have a lot of experience with this valve, having done more than 50 implants for this. What this does, I'll show you a video. It basically goes down into the sinus. It is 100% commissural alignment, and it allows complete coronary access. In fact, you can go to about it's so commissurally aligned that if you have a left main or a right main that's 3 millimeters above the annulus, you can still use this valve. It is quite amazing as far as coronary access for this valve. And so you push it down, the 3 locators, you put them in exact commissural alignment, and then you grab the leaflets with the locators, and then when you're happy with this, you deploy the distal portion of this. Like I mentioned yesterday, this has been now published in Lancet, the original series, and was presented before the original series, 180 patients. These are all high-risk patients, no low risk, no intermediate, all high-risk patients. You can see about 76, age was 76, and the STS score was 4, and a large percentage of them had frailty associated with it. Almost all of them had either moderate severe or severe. There are some patients you see that say moderate or non-evaluable. This is by the core lab site. We did look at the patient site also, which all had severe. In total, if you look at the on the bottom right, the CT annulus perimeter, the average is 78.7. This valve has a maximum of 90 millimeters. Now, this is different outcomes than what I just showed you with instead of a 14% failure rate. Here you see a much better success rate of 95%. So the technical success is 95% overall, much better than the 84% I showed you before. Before I showed you a mortality of 11%, now I'm showing you a mortality of 4%. So much, mortality of 2.2%. You can see much better. We've been able to, with dedicated devices, have been able to cut the mortality from 11 to 2. So I think that's a huge impact across the board. I also mentioned this yesterday. Pacemaker rate is about 25%, 16 to 24%, depending on how you look at it. And look at the rate of moderate or paravalvular regurgitation, almost zero. So you've seen a major improvement with dedicated valves versus non-dedicated valves. I'll just show you overall that this met the primary safety endpoint. This is the data that the FDA will be looking at in the United States. So we not only did we meet the early, but we also met the 1-year efficacy endpoint, which with a 7.8% all-cause mortality, and that's at 1 year. Quite amazing, I think, for high-risk patients across the board. So the pacemaker rate has come down. And the reason that the pacemaker rate has come down is because we didn't know how to size this valve. We were oversizing everything like we did in aortic stenosis. Then we realized you don't need to oversize it, and you don't need to push down very hard into the sinus, into the annulus. So by relaxing the valve a little bit and not oversizing it like we did, you can see that the patient over time has come down from mortality. I actually have used this valve for aortic stenosis, and it had the best gradients I've ever seen. Almost every valve has a gradient of less than 5 across the board. And here you can see the 180 patients for AR had a mean gradient of 4. There is nowhere else in the published literature that shows better gradients than this valve does. So it's quite amazing across the board. Here you can see that almost everybody had non-trace or mild. Really 0% of patients at a year have moderate or severe. As we've seen in the surgical literature, once you get rid of aortic regurgitation, the LV remodels. And here you can see indications across the board of a significant LV remodeling in all 4 categories. This was just presented. Again, I mentioned this. This is by we've taken the 180 patients, and we've now increased it to 500 patients. And here you can see the STS score is somewhat maintained, about 4% for all the patients. The age is also maintained at about 77 years of age. And what you see is the screening. Again, every patient is screened in a follow-up or on a call on a Friday afternoon. And you can see that we've now added 100, from the 180, we added 320 patients with a full 500 patients. They have echo, CT, and all the criteria were met. And now not only do we have 1-year follow-up that we presented in the 180 patients, but we also have 2-year follow-up on a big chunk of these patients, not all of them. You can see that at the end of the day, we still have 0% intraprocedural death with these patients, so it's quite remarkable what we've done in a first-generation valve. And a technical success of 96%. Remember, I showed you with non-dedicated valves, it was 84% success rate from a procedure. And so overall, unbelievable outcomes when we look at this. When we look at all 30 days for all of the patients, we still quite significantly had below the pre-specified non-inferiority margin with the FDA. And so at the end of the day, we show now an all-cause mortality of 1.4%. Remember, still high-risk patients. So we went from a 14%, 11 to 12% mortality to a 2.2% mortality. Now with additional patients, we're at 1.4% mortality. I think this is great for what we've done with a first-generation valve. I still think the biggest deficit for this valve is the pacemaker rate. You can see it did not drop very much, about to 23%. Again, near 0 moderate severe regurgitation rate. So overall, you can see when we break it down, the 320 patients actually have a less than a 1% mortality. It is very hard to beat that, quite honestly, for high-risk patient population. So we've gone from 2.2 to 0.9. The pacemaker rate has stayed the same, about 24 to 23%. This is the efficacy endpoint at 1 year, which we just showed. We're planning on submitting this to Journal of American College of Cardiology, JACC. We're in the process of writing the paper up now. And here you can see overall at 2 years, the mortality is 15%. Remember, this is a high-risk patient population, so we're actually very happy with this type of mortality. Look at the valve performance. It quite honestly is unrivaled. Nowhere else in any of the other catheter valves do we ever show a sub-5 paravalvular or a mean gradient. It just does not exist. Partly because we get the leaflets and we open it. So when you get a true stentless valve here, unlike all of the other valves that you're getting. Again, pretty much zero moderate or severe paravalvular regurgitation. We do see great remodeling of these patients when we look at the 3 different parameters. Functional class is improved across the board for these patients. And the quality of KCCQ is unbelievable compared to 58 points. It goes to now almost 80 to 84 points. Just as a reference, this 27 valve is the most common, and I'll talk about the J valve in a minute. Right bundle branch block and an annual parameter greater than 85, i.e. a larger valve, is the main reasons to have a pacemaker. So we've shown in this study, in the largest cohort ever presented with high-risk patients with a univalve, actually unbelievable outcomes that we believe are so far have never been that we've ever seen in these patient population. So this is a trial that's starting. It's actually going through our IRB now. I already have 5 patients ready to randomize. I'm just waiting for our IRB at Piedmont Heart Institute to get these going. We're going to do a 1,000-patient trial. This will be the first trial in aortic regurgitation that will be randomized to all comers, low and intermediate risk. Of course, high risk, we've already done a 500-patient study to show that. Also, we are in the process, and it's going through our IRBs for a VAD registry. As you know, there are a lot of VAD patients that have aortic regurgitation, and we're waiting for that to kick in. This is just the most recent publication. Univalve is commercially available in Europe, and they do AS and AR, and the results have been spectacular with that. I do want to show some slides of J-valve. I was part of the early feasibility study, but they closed the 10-patient trial, 15-patient trial before I actually got a patient in. So even though I was part of the EFS study, I actually did not randomize a patient. We are part of this. It has now been bought by Edwards Life Sciences, and the trial is going to be starting soon, and we have just gotten approval for this from our IRB, so next year I'll be able to tell you some real-life experience with this. This is a little bit different in the sense that it does have the same locators, but it's a little bit shorter valve. It can treat, you can see 104 millimeters. The univalve has a cap at 90 millimeters, even though personally I've done a 95 millimeter valve. This is just some differences between the two. The data has been somewhat sparse, quite honestly. The only data that's so far been in the public domain is a 30-day endpoint, not a 1-year, not a 2-year. And here you can see that they have had 15 patients that they presented with a low morbidity and low mortality. You can see a lot of zeros there, but this only in 15 patients, and I think these are somewhat highly selective, quite honestly. This really needs to be further vetted out into much larger patient population. The Journey pivotal trial overview, this is for high-risk patients, is undergoing now by Edwards Life Sciences, 170 patients in 25 sites in the US and Canada. And this is the regular stuff that we have for this. The study leadership is Dr. Kaneko and Dr. Garcia, and Dr. Reardon, Dr. Kyriakis are the study chairs, and David Cohen is the study director for this. So in conclusion, yes, TAVR is coming for AR. Whether you like it or not, it is there. It's coming. For the surgeons in the group, it's here. I've done a lot of these, and it works very well. If we can figure out the pacemaker rate, it is the holy grail. We have to address the gap in treatment for this. I think the ARTIST trial will be a absolutely generational trial that will now look at AR in low and intermediate risk patients. The J-valve trial is now in the U.S. is high risk, is enrolling now. I think other dedicated systems, which I didn't have time to get into, are very much forthcoming. There are 4 new AR valves that are in the market, so it'll be interesting to see what happens with these. Thank you very much.
Okay, so Vino, you convinced us that the current prostheses are ready for prime time. Do you know who were the patient who got device failure? Was this a technical aspect? And what is the learning curve when you're a TAVR operator for this valve?
Yeah, I think there were some technical issues. One, we had some dissections early on, partly, and then we had some strokes early on. And part of it is that we were running the ACT a little bit on the lower side. And the way that the univalve works is that the sheath goes all the way up to the SDJ. So the delivery sheath goes all, and at that point, actually, we had to have a pause in the trial because we were getting some blood clots. I think it's because the sheath was filling up with some clot or something. So we actually moved our ACT a little higher, and all of a sudden, all of it went away. So we saw some early strokes that were ameliorated with a little bit higher ACT because of the sheath is going all the way into the SGJ. Second is that people, when we first were doing these, we had 1 to 2 dissections. Partly because of the sheath and the movement of the sheath, people didn't realize it. And so after you expose the valve, we actually bring the sheath all the way now back into the descending aorta, and all of a sudden our dissections went away. And then also, movement of the valve, we're a lot more deliberate about it, because once you expose the valve, if you move it like you do a core valve or a navitor, you can cause some dissection of the aorta. And we had some of those issues, which all went away after we changed some protocols. And so all of the complications we had, almost all of them were in the first 30 or 40 patients. As a Gen 1 program, we figured all of that out, and since then the complication rate basically becomes a pacemaker. And so that's why you saw the mortality go from 2% of the first 180 patients to 0.9% in the next 320 patients. So the learning curve, unfortunately, 4 or 5 sites in the U.S., we figured out the learning curve with our friends in Europe, and then now we basically, as pacemakers, the only complication rate we have.
So, being a great presentation, but one thing I'm curious, these are pure AR patients. So my curiosity is, what is the theology beyond this AR? Because these were 75 years old, no? So is this subtype of degenerative calcific disease? Or, because usually you see this with dilatation of the root, and then what's the etiology underlying these patients? I mean, is it difficult to include these patients? I mean, there aren't so many, no?
So we first thought that also, Martha. And when we first started the study, I was actually at Emory at the time, and we did calls once a month, and we would get 2 patients on. And now we do a call every Wednesday, and we have 4 or 5 or 6 patients on. And that in the U.S. is only in 10 or 15 sites. I think just like we first thought when we did the Partner 1B study, that there's no extreme risk patients who can have TAVR. Guess what? It is now 1/3 of the population. So I think they're out there. I think when people have a device that doesn't have surgery involved in it, all of a sudden they start coming out. So just in 10 or 12 sites, we have 5 or 6 patients in the U.S. Every Friday we have a call. And so it's, I think awareness is what it really requires. I think we're not, and we talked about it earlier, I think AI will really help us find these patients, because a general cardiologist in the community thinks that surgery is the only option, and some patients just do not want surgery. Whether we like it, and we can talk about how great we are, patients don't want their chest open. And so I think I think they're out there, we just have to find them.
How do you see the next step? Or maybe that question also to the next speaker. I mean, you see an aortic root tubular prosthesis with the valve inside, percutaneous?
Yeah, I think that there have been some early designs for root replacement or Bentall procedure with this, and I think that's forthcoming. I do see that coming up in the next decade. And there's been some 1 or 2 cases, but it's not ready for prime time.
So, thank you. Yeah. Let's move to the next speaker. It's my pleasure to introduce Samir Kapadia, who is a cardiologist, needs no presentation, Chief of Cardiology at the Cleveland Clinic in Ohio. And moving forward, technological advancements. An initial field that was kind of prohibitive for TAVR, which was bicuspid aortic valve. And now we have novelties, and he will talk about the latest advances in these fields. Samir, the floor is yours.
Yeah,
if you have the slides.
I do. He's making it.
Just a side note, Samir is, the new, as of tomorrow, will be the president of the Heart Valve Society.
That's
and
very
so
important. I forgot. Thank you, Vino.
So if you have ideas for next year's meeting,
please
find him, tackle him, and tell him what you'd like to see next year.
And if anybody wants to come and get involved with the new program or anything like that, feel free to reach out to me. And Dr. Thurani is also going to be helping. Marta will be helping. So any one of us can help us. I volunteered you both, but so with that in mind, my talk was what is in the bicuspid aortic valve. What are the things that we need to learn? Of course, you know about the bicuspid aortic valve, most of the people here do, that what are the most different ways we classify the bicuspid aortic valve. And there is a unanimous or whatever the consensus of the classification, because this is important, that you have type 1, type 2, and what are the most common fused raphes that exist. This is important more so for the transcatheter therapies than for the surgical also is important, but more important the transcatheter therapies, because how we measure and how we dilate the valve and how we place the new valve depends on the raphe and how calcified is the raphe and how the valve will move to one side or the other side depending on how calcified the raphe is. So these are important things to keep in mind. If you look at this is a very old classic paper by Robert Roberts to say that what are the most common variants, but my point of showing this slide is to say that there can be bicuspid aortic valves that have very small raphe and very mildly fused. So when we look at the literature to say that we did it in bicuspid aortic valve TAVRs, you have to pay attention to it, that what kind of bicuspid valve people treated, because it's very possible that they have, as you see in one of these things in the bottom right, that this kind of a small fused bicuspid raphe is different than having a bicuspid which have very calcified raphe like on the right side. So the other part is that the bicuspid aortic valve, what is the age of the patients, that what at 8 different ages do you have bicuspid aortic valve or not. And it is true that even in the patients who are more than 75, there are a lot of patients with bicuspid aortic valve. So when we are talking about the new data that are going to be available or not, we are talking about young patients with bicuspid aortic valve that needs to be randomized. However, in all valve trials, we did include in the intermediate risk, high risk, and even for the low risk, we did include patients who had bicuspid aortic valve as a registry. And this registry data are available but there's no comparator. There was no surgery for those patients. So there's just a bicuspid aortic valve. Registries were available from PARTNER and Evolute trials, both these trials. And this is how the FDA labeling for the bicuspid aortic valve has happened, where we are able to do the bicuspid aortic valve in older patients. But this does exist. So if you look at the PARTNER 3, so this is the PARTNER 3 trial. So in the PARTNER 3 trial, as you can see, we have a P3 bicuspid TAVR registry. So these are the patients who are low risk, who were screened, and then they went to the bicuspid registry. And then after the enrollment was finished, we had a P3 bicuspid CAP, continuous access registry, again going on with that. So there are two kinds of patients that were included in the registry. And so if you look at these patients, we have 71 and 98, so we have total 169 patients that were included. And then, of course, the way the FDA got the approval, or the FDA considers approval, is to somehow compare it to tricuspid aortic valve for TAVR. And so we compare this bicuspid registry, include both of them, and of course they have, as you can see, they have severe aortic calcification, and they are, as you can see, again, the type 0, type 1, and type 2. Most commonly, we are treating mostly the type 1 raphe patients, and this is the most common type that is treated by TAVR. And the primary endpoint, which is death, stroke, and rehospitalization, was no different, was exactly the same as tricuspid versus bicuspid. And if you look at here, as you can see, the death slightly, numerically higher, but not different at 30 days, but still death, stroke, and rehospitalization of 6.8%, death 0, stroke 1.4, and rehospitalization 5.4, and new pacemaker 6%. So in this particular group, there was no difference between the two. Paravalvular regurgitation is a little bit higher, as you can see here, and this is the, it is mild paravalvular regurgitation is 25% of the patient, and that is typically true for all the TAVR trials. and moderate or moderately severe is rare, it is about 2%. This is I personally don't buy into this, but I just want to make it aware that this exists. So if you look at this LIRA method of measurement, what this means is that you measure the valve, as you can see here. I can try to point it out, but doesn't matter. So if you can see the yellow line, so yellow line is the line where the raphe is calcified. So now you take the yellow line, and you, at the yellow line level, you measure the valve annular size. So you don't really measure the valve annular size, but what you measure, what you see in this bottom picture, in this multiple thing, is that you trace the valve inside. So the leaflet, how long are the leaflets inside of the valve? And then you create a perimeter, and then that perimeter you use to derive the valve size. So this is a method that this Italian group popularized to say that this is the way, is one method of measuring. I personally think that this is useful in less than 10% of people. Most commonly, I myself measure just the annulus. If the annular measurement is totally disproportionate to the sinus size or STJ size, then you may want to look into this, because this will give you a smaller size valve rather than a larger size valve. So this method is so. There is some literature, so you will see a lot of papers saying that this method was slightly better than the other method, but I personally don't think that is the case. Now, if you look at the data, so there are 3 different ways the data has been analyzed, and I'll just summarize it for you because it's kind of confusing. So TVT registry has a method of analyzing the data, which is core valve or the evolute valve, Medtronic valve, and the sapien valve together. So this is in the TVT registry. Now, both the Edwards and the Medtronic own their own data. So they can analyze their own data irrespective of the TVT registry. In the TVT registry, we cannot compare the valves because that is a method that has been suggested to us that we cannot compare the valve. So now we have 3 different analyses. So one analysis is a combined analysis. So this is the combined analysis. That's why I call it a Duke analysis. So this is 170,000 patients, 590 sites, 3.2% bicuspid valve, so not many bicuspid valve, and as you can see there, 3,700 were S3 or evolute. The rest were older generation valves. So if you want to look at S3 and evolute, it is about 3,400 patients, 700 patients. And here you can look at it, the device success is 93% with the current generation valves, 96%, and 2+ AR is 2.7%. So it decreased from 14% to 2% by the newer generation valves. And 2+ AI was, as you can see in the bicuspid valve, was slightly higher than the tricuspid valve. And the self-expanding valve and balloon expandable valve, AI was a little bit more with self-expanding valve, 3 times more compared to balloon expandable valve. If you look at the Edwards analysis, so this was done from 2015 to 2018, and now this is just the Edwards valve, so these are 2,690 valves. And here you can see that the STS score is 4.5, so it is high-risk patients, intermediate or high risk. And the conversion to open heart surgery was a little bit more, 0.9 versus 0.4, and annular rupture was a little bit more, 0.3 to 0. So this is important to keep in mind that the conversion to open heart surgery is a little bit more with balloon expandable valves, which we did not see in the combined analysis. In-hospital outcome of stroke was 2.1 versus 1.2, again, a little bit higher with the bicuspid aortic valve compared to the tricuspid aortic valve. Only 15% of the patients had emboli protection in this particular analysis that we reported. And if you look at the stroke, major stroke, 1-year stroke was no different ultimately. And new pacemaker rate was 9.1 versus 7.5. And at 1 year was 10 versus 8.6. So these are the numbers for the balloon expandable valves. And if you go to the self-expanding valves, so this is the Medtronic self-expanding valves. So there the patients are a little bit less, 1,000 patients. And if you look at these 1,000 patients, again, the numbers are there, 4.2, same STS score, moderately high. And sorry. And so here you can see that the procedure time and the recapture was different, but the all-cause mortality in this particular analysis is a little bit worse. So in the Medtronic analysis, the all-cause mortality was 1.7 versus 0.8, no difference in the balloon expandable valve. And then if you follow them in the TVT registry, again, you can see that the all-cause mortality was changing in these valves. Higher gradients were seen in the eye. So I summarized it here to say that the higher gradients with self-expanding valve compared to the tricuspid valve, when you put a self-expanding valve, maybe because it doesn't expand fully, higher earlier mortality, and more AR was seen with the Evolute, but not so much with the Pro, the newer generation of self-expanding valve. Balloon expandable valve, the higher early stroke rate was seen, more root injuries were seen, and higher pacemaker rates were seen. So these were the two things that we identified from this analysis to keep in mind. I just want to say that the proper sizing is very important. As I said, annular is better. Aortic dissection prevention is super important, so you want to pre-dilate the valve so you don't have to push the valve inside of the valve because the aortic dissection happens because the aortopathy most commonly associated with the bicuspid valve. Slow inflation when you do balloon expandable valve. Paravalvular regurgitation, many times we post-dilate, but sometimes putting a plug is better and easier because the annular trauma can be dangerous. And the coronary protection is important. The coronary artery occlusion rate is a little bit higher with a bicuspid valve. So if you are in doubt, you may want to consider to protect the coronaries. Stroke prevention, the CEP is important. And balloon expandable valve, if there is aortopathy, is better, in my opinion, than the self-expanding valve because it does not touch the ascending aorta. This is a good paper. Everybody got together and said that how do we decide that what are the data available for the bicuspid aortic valve and what are the new things what are the gaps, what are the things that we need to learn. And then, of course, we need a randomized trial, but there are a lot of different designs of the randomized trial that have been proposed. Then Dr. Thurani is also trying to generate a trial. Of course, these are not yet funded, but the funding is in the process to see if we can decide the funding. But these are the trial. And Notion trial, of course, with 25 patients in each group, shows worse outcomes with TAVR compared to surgery. This was stratified randomization. So this is something to keep in mind. Death and disabling stroke in bicuspid cohort was a little bit worse. So it's rapidly evolving field. We need more data and huge opportunity for TAVR trials.
Samir, excellent presentation. So in terms of these trial and registry, are we reporting the calcium scoring in each of the group? Because is the worst outcome in terms of PV leaks or stroke related to the morphology of the valve or the extension of calcification? And should it be pertinent to include and compare the same degree?
So we did compare the bicuspid valve calcification to tricuspid valve. So as you know, the calcification is much higher for the same amount of stenosis with the bicuspid valve compared to a tricuspid valve. And so even though there is higher calcification, that may be the reason for both the stroke and the PVL. There are no bicuspid valves with less calcium that we find that easily. And so the trials will will have some way to stratify because Raj's paper suggested that if you have too much calcium in the raphe, then there is a little bit more chance of having stroke or PVL. So those patients may be excluded. But this is the challenge of the clinical trial. So that when you do the clinical trial, you select the patients, and when you interpret the trial, you don't select the patients or you don't restrict it to that.
Yeah, I think that's what I was going to comment on. I think we have to be very careful that when we accept a trial, it has the guardrails of not a lot of Seaver zeros. The guardrails of not the Commerce Journal, but when that gets published in, let's say, New England Journal of Medicine, it doesn't say in the conclusions with guidelines or with guardrails.
That's what I'm saying.
And then the other person who does them doesn't think oh yeah, I can just do any bicuspid valve. So we have to be very important. It's important for us to be able to make sure that the interpretation of the data is really correct.
And also, when you write the paper, I think some pictures of the inclusion is super important, because no journals allow you to put pictures in the methods. But I think this is where the picture would be super important, and especially in the supplement somewhere, so that people can understand what you are excluding and what you are including, because this is crucial.
Just to remind everybody, in the United States, last year there were 105,000 TAVRs done. So in the U.S. alone, there are 105,000 TAVRs done in just the U.S. And so if we had, a 0.9, if they're all bicuspid, they're not. If 20% were bicuspid and 1% of those has a complication, then you're looking at 200 patients that potentially have a rupture in bicuspid population. That's not trivial at all. That weighs on me heavily.
So the modern cardiac surgeon will be busy.
I tell you, yes.
Yeah, it is true.
Okay. Thank you, sir.
Thank you, Samir. Thank you.
Go ahead.
Let's move to the last speaker. So we are going back to the procedural planning, and it's my pleasure to introduce Courtney Rian, who will discuss the optimal planning for TAVR procedures. So we have learned a lot on new technologies, new type of patients, and new anatomy. So pre-procedural planning of most importance. Please, the floor is yours.
Thank you for the introduction. It's a great pleasure to be here today to present on behalf of Dr. Dasi, who unfortunately couldn't be here today. I will be talking about optimal planning for TAVR procedures. I'll be giving a high-level overview of Dasi simulations and what they do. Here are his disclosures. So first to start, I'll be talking about the surgical and interventional decisions that are made without predictive modeling guidance. So first we have the manual planning options. So this is what we consider static planning. Using CT imaging, you can take various anatomical measurements to be able to plan for your TAVR device. You can also overlay specific devices and take these anatomical measurements as well. With this being a manual process, you have to do this for each device you are considering deploying for that patient, which can be a bit of a time-consuming process. And also with this comes the potential for human error, which is usually around 15 to 20%. So next we have to consider our options for our final treatment decision. This is not a completely personalized decision for the patient, as you cannot, with static planning, predict the anatomical device interactions. It's a bit difficult to differentiate between these options because of that. And another thing that Dr. Fukuhara introduced earlier in his talk is the concept of lifetime management. And with using the static planning, it's much more difficult to optimally plan for the very first TAVR for that patient. So the consequences of some of this, alongside increased costs, fatal complications do happen. This is sometimes unavoidable, but I'll talk about later. This can be prevented for many of these cases with the addition of predictive 3D computational modeling. Again, this patient with lifetime management planning may have to undergo various subsequent procedures such as redo TAVR or TAVR explant, and this must also be considered but can't be predicted very well with just static planning and manual measurements. So this, for the patient, can lock them into a dangerous path, as especially with redo TAVR, that annulus size or the orifice area will decrease with the implantation of more and more devices throughout their lifetime, or with explant, as some of these complications have been outlined, is a very dangerous procedure and also requires a very high skill level for the surgeon. So now I'm going to introduce a new paradigm for decision making, and that is DASI simulations, which is a physics-based AI computational predictive model. So here you can see on the right is an aortic root model. You can see the ascending aorta, the coronaries, LVOT, and each of these native leaflets highlighted in different colors, as well as the calcification. So this is a dynamic model, so you can specifically look at the device-tissue interaction. And this is a newer concept, at least in the United States, through the eyes of the FDA. This is a medical device. So this is the concept of software as a medical device, and it is CMS reimbursed. So to outline the DASI technology, we begin with pre-TAVR CT scans, and as you can see here on the left, we are able to create these models via a process called segmentation. So you can see that model in the middle there. Has each of the leaflets, and we were able to model this native patient anatomy prior to the procedure and be able to simulate the deployment of, here on the right you can see, for example, a Medtronic core valve, or also balloon expandable options. We have a variety of valves we were able to simulate prior to the procedure. So here's kind of an overview. The technology at this point is also an app as a generative platform for lifetime management, meaning that the user can interact with the platform and be able to see the outputs in real time. So here's an example of an aortic root model, the expansion of a core valve inside of it. You can change the different devices, change the transparency, manipulate the model, and be able to adjust the deployment depths as well to see how this can potentially sit within the valve, and also be able to take various anatomical measurements in real time and see how these measurements actually change as you change the valve type, as you change the deployment depth, as you are using it. Here again, you can see the cross-sectional area, which can help you look at the distance between the device and the aortic root and be able to identify potential PVL gaps as well. Make a bunch of cross-sections, and then also this is highlighting the lifetime management component where you can simulate a redo TAVR inside of it as well and be able to manipulate both of those deployment depths. Here in these hotspot regions, this is showing the displacement of the aortic root and how this could potentially correlate with root damage, root injury. Okay, and another feature that we do have is the ability to simulate a basilica procedure. So this is a TAV and SAV for both a balloon expandable and also a self-expanding valve here on the left. So that allows you to be able to see what a basilica would look like or using the shortcut device and manipulate whether you would like to place that cut right in the middle or if you want to make an adjacent cut with respect to the coronary ostia that could be potentially obstructed. Next, we can also predict paravalvular leak. So this is a risk estimation that we provide. This uses computational fluid dynamics to assess where these gaps might be between the prosthesis and with the root. You can see the streamlines here on the left. And here's the clinical interpretation. So you can see a PVL jet and how this correlates to real post-procedural echo data, and you can identify that jet there on the right. So that is how we essentially better our algorithm and validate the model, is by collectively using echo data for this. Next, as I had mentioned before, instead of just relying on calcium volume, you can also be able to visualize the potential for root deformation and risk for injury. So here's a model on the left. This was a real retrospective case that exhibited aortic root damage here in one of the sinuses. This is a bicuspid aortic anatomy, which is generally more challenging, as we just heard, to predict, but this allows you to visualize it, and we both have a quantification metric. So a stretch above 1.5, 1.6, you see that scale on the left, would identify as a high risk for injury. And we can also localize that here on the right in each cusp. So then here's the optimization component. Let's say you have a patient and we model it. We model a balloon expandable 26 at nominal volume. We can also model with minus cc's to be able to see how that valve can reduce the risk of root rupture. So we can simulate many different options, and then on the other end of things, let's say you have a patient with large gaps in the annulus, you're worried about PVL, we can also model additional cc's and see what that would look like as well, so you can determine whether to add volume or size up or down. And then for pacemaker reduction, we can also see, if you see these arrows here on the left and the right, these are force vectors to look at the radial force on the stent in comparison to the membranous septum. This is another way we can kind of quantify risk for needing to implant a pacemaker for that patient. So we do have a negative PPI patient on the left, and then on the right, you can see larger force vectors. This patient actually required a pacemaker later on. Another feature that we do have, I could keep going on, is a gradient prediction. So we use pre-procedural data to then evaluate what the post-procedural gradients would look like for different types of valves. This is still being validated. We had some work published back in 2023 on this, but this is what the final report would look like, and we are still in the process of validating this model. I'd like to highlight my colleague, Wenyuan Song, who worked on this over at Georgia Tech. And you can see here, this blue line at the very top is from the pre-procedural echo data. And then this is the prediction in red, that line there, is what we can predict for a SAPIEN 23, for example. We can get the mean gradient and also predict the peak gradient. So again, we're still working on validating this. It's an AI-based model. And another feature that we have is hypoattenuated leaflet thickening prediction, also from pre-TAVR CT data. So my colleague Aniket Venkatesh worked on this. His work was published back in January in JTCVS. And using a similar methodology here, we can create an aortic root model, simulate a balloon or self-expanding valve. And then essentially what this is a machine learning model. You can analyze various geometric parameters, such as neosinus area, for example. And what we're trying to do is correlate some of these geometric parameters to halt risk. So here on the, here in the next slide, you can see we perform various machine learning assessments, determine the area under the curve, and see how well these parameters correlate with halt prediction. And finally, just to wrap this up, predictive modeling does eliminate some of the guesswork that comes with TAVR planning. And again, going back to the lifetime management component, instead of just determining the size of the valve, it's really important to optimally determine not just the valve type and not just the size, but also the deployment depth and many other structural parameters and how this could potentially impact risk of complications. So in general, what we want to do is democratize the clinical intuition across centers, give physicians more confidence, not replace any of the general consensus that we have here, but really be used as a third-party tool to help give physicians more confidence in their procedural planning. So thank you. Thank you.
That's a great job, Courtney.
Great job.
Yeah.
Congratulations.
I think we have maybe 1 minute for discussions or any questions. Any questions from the audience? Looks like one. Yep.
Hi, Cassandra Cliff from Brigham and Women's and Harvard Medical. So I'm actually over on the basic science side, and I'm curious, for some of these models, I noticed that you're incorporating calcific burden into the model, but just from our experience with explanted valves, a lot of the time I can actually tell the difference between like a male and a female valve just from the look of them, because the female valves tend to be more extracellular matrix dominated as opposed to calcific, but still being removed at that same end stage, right? So do you have kind of like a future endeavor to incorporate more ECM material properties as opposed to just calcific burden?
Yes, that definitely would be something to consider. Right now it's very challenging to incorporate some of these components on a small level scale, but this would be something certainly to consider, especially also with valve endothelialization, for example. That's something we can't really take into account right now, but with data as it keeps coming in the future, we would like to consider this as well.
And we've never separated out male and female, so that'll be an interesting component of how to look at that. So that's a great idea.
Thank you.
I have another question, quick question. So, I mean, congratulations. I think this is the real future and the precision medicine. My question is, have you already compared how does the physician select the prosthesis and the machine, and what's the concordance, particularly for predicting pacemaker and halt, which I would say are the biggest still limitations, no?
Yes, there is an ongoing study that we have been doing with, I believe, a group in Canada, especially for bicuspid patients, to determine how their valve selection differs from what we would select based off of, at least for coronary obstruction, that's a study we're working on, but it would be interesting to see across different institutions how their selection process would compare to what we predict they should, or what we suggest they might be able to use or should use. So that would be interesting as well.
Thank you so much. Maybe for the sake of time, we need to end because of the lunch sessions. Thank you, Courtney. There are 2 lunch sessions. One that's in this room, the Future of Aortic Arch Solutions, update on clinical results and latest innovations. And that is supported by Artivion. Right to the outside, to the left in Canyon 3 is beyond the initial choice, what lifetime management really means for aortic valve disease, and that's supported by Corsium. So those are the 2 lunches, one in here and one next door to the left. Thank you. Great session, Marta, Jessica.